My name is Rebecca. I work at KMHC as Manager of Prevention Services. And I also sit on the Family and Gender-Based Violence Action Group. So we meet on a monthly basis and we try and figure out resources, different events, workshops, information that we think might be helpful for community members to raise awareness on gender-based violence and family violence. Right now we're in the middle of the 12 days of action against violence against women. It started on the 25th of November and it runs straight through till the 6th of December. It's a province-wide campaign. It ends on the 6th of December as a memorial to the Polytechnique massacre. Dr. St. Cyr sits on our Family and Gender-Based Violence Action Group. We're very lucky to have her on our committee. And as we were planning for events to have throughout the 12 days, Dr. St. Cyr said, hey, I can do a workshop on trauma responses. As we know that these are responses, and Dr. St. Cyr will get into it a lot more, that occur as a result of being sometimes in a relationship or in a situation of violence, but kind of how those show up and the ways of being able to manage those is what we're going to focus on today. So I'm really happy. Thank you so much for coming. So without further ado, I want to introduce Dr. Catherine St. Cyr.
Hi, I'm thrilled to be here, and I'm excited that so many people came. It's a little nerve-wracking, but that's okay. So a couple of things. I do prenatal care and women's health in Milwaukee, and work also at L'Auberge Hospital in the delivery room and on wards doing hospice medicine. Before medicine, I was actually an intervention worker at a home shelter for young women, and prior to that, worked in family planning services for several years. So I have a bit of history with these sorts of topics. This is the first time giving a talk specifically on trauma, but it's obviously a subject that's near and dear to my heart, and something that we see a lot of in every aspect of healthcare and every aspect of social work. And what I wanted to know even before starting, because I have a sort of a basic overview of what trauma is, what the trauma responses are, the fundamentals on management, as well as a reference list and reading list, but I wanted to know what people would like to know. What should I make sure that I touch on? What should I make sure that we go over? What are the questions that you might have that you already know, like I'm here because I want to know more about this, and then make sure, and I'll make sure I integrate it.
Yeah. Kids trauma response.
Yes, okay. Absolutely. They share all of them. They with us, yeah, exactly. But we'll talk about the acute and chronic. So that's the chronic. Kids, you'll often see a lot more of the chronic stuff happening, so yeah. Anything outside of it?
Yeah. I've seen before in some sites where we work in medical imaging, and I've seen some sites, especially in the hospital setting, where resources within the hospital are used to whether separate victims from potential abusers, like medical imaging, and then so that they can figure out what's going on.
Yep.
That would be something that I would like to know is how we do that.
What we can do when we suspect it in our practices, if we're healthcare providers, yeah, that's a good idea. That's not something I addressed in here, but yeah, we can talk about that for sure. Actually, I could probably do that now. Like, I mean, this is something I deal with a lot because I do women's health, so oftentimes physical exams are an easy time to try and sort of get somebody away from someone that you're worried about the vibe. One thing to remember is that our instincts are very, very powerful. I don't know if you guys have read Gavin de Becker's book, The Gift of Fear, but it's a really, really good book. And it talks about how intuition is just another way of knowing. It's our senses working, but at a subconscious level. And so whenever you meet somebody with somebody and you're like, there's something off about this, I'm not sure what's up and it's off. It's not just emotion, it really is intellectual processing that's happening on a subconscious level, and it doesn't necessarily mean it's always accurate. There's a lot of things that can make that can make your alarm bells more or less sensitive, but yeah, you need to trust that and try to do what you can to get more information. But we'll talk a lot about how trauma responses will not always make it easy to intervene either, and it won't always make it easy to come to someone's help, for example. Yeah.
What about that, being able to separate that intuition and trauma response? Sometimes we feel like we you're picking up on things that could just be a result of trauma.
From you, I see what you mean.
Yeah.
Yeah,
Like
yeah,
being
that's a
able
good
to
point.
separate the two, you know?
Yeah, that's a good point, that's a good point. Yeah, I guess it's harder, it's harder when the situation involves you, right?
Yeah, is there ways to recognize that? I mean, like,
I think you can look at external cues, like is the situation that I'm responding to, is my actual well-being or that of those around me in any way affected by this? And if it is, then obviously there might be some blurring there. But then again, at the same time, one could argue that when our own safety is in play, actually in some ways our responses are more accurate. So I'm not sure there's an easy solution for that. I feel like then you gather information. The problem what trauma does is that it makes you not trust yourself, and it makes you not trust your responses and your instincts. And so that's important. I would say I'd rather somebody trust their instincts and investigate more rather than blunt them or assume that it's their own trauma topic. Okay, so I mean this is obviously like the classic definition, but maybe trauma itself is a disturbing experience that results in fear, helplessness, dissociation, confusion, or basically disruptive feelings that are intense enough to have a long-lasting effect on a person's attitude, behavior, and functioning. And I mean, we all kind of know the working definition, I think. But it's worth saying that the older definitions used to basically imply that you had to be in fear for your life or that you had to be in physical harm or physical damage, and that's actually no longer the case. Like we know now that other aspects of your wellness can be seriously compromised, and feelings, for example, of confusion, helplessness, and fear, even if they're not linked to your survival directly, can still make your body react as if your survival is in danger. So, and it's important to keep that in mind. We used to call it shell shock back in the day. People would come back from war and would have what we now know as PTSD, but it wasn't really the word that was used. It was considered a personal flaw that people got this, even though everybody got this, literally everybody, that went through these things for the most part. So there are definitions too, actually, about what is sort of acute versus chronic. And in this case, we talk about a month is sort of medically what we consider to be the limit. So basically, if something happens for the first month of dealing with an event to trigger an incident that was traumatizing, we consider that to still be considered acute trauma. And it includes the immediate physiological responses that we're going to go into it, as well as some of the medium-term social responses and the sort of the medium-term physiological responses, because these incidents aren't just in the moment, they leave traces for quite a long time, and even once people have processed them and integrated them, they can change you thereafter as well. We call things that are chronic trauma. I mean, obviously there's chronic repeating trauma, and then there's the chronic effects of sort of a more immediate, like one-time trauma. But in general, things are chronic if it's been more than a month since the event or the first event. It includes long-term conditions like post-traumatic stress disorder, which you've all heard of. And it also includes long-term social responses. So we're going to talk a little bit about trauma bonding. We're going to talk about learned helplessness. I didn't think to include external locus of control, but we can talk about that too if you wanted to. It's kind of a psychological concept that's really interesting on this. And while we can differentiate the two, a lot of what happens with chronic trauma is relivings of acute trauma by other triggers or by memories or by flashbacks that act as if they are secondary events, even if there are no secondary events. And so all chronic trauma is in a certain way repeat trauma, even if there was only one event to start with, if you know what I mean. If a lot of you are working in social services, you probably have heard about the Adverse Childhood Event Scale. This is it's actually a questionnaire that has 10 very clear and very serious questions about events that that could have happened in childhood that can cause trauma in children. And it was actually developed in California when they did a treatment plan for patients who had severe obesity. And at one point, one of the questionnaires, they would take people's weight history. One of the questions was, at what age were you at when you became sexually active or something like that? But instead, they asked, because the other questions were, at what weight were you at when you had blah, 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 your child, whatever. So somebody mixed up the questionnaire and said, what weight were you when you first became sexually active? And the woman answered 60 pounds and started crying. And then it became clear that there'd been some childhood sexual trauma that had caused the person's defense responses to be to overeat, to get larger, to become hopefully undesirable, to create a barrier, and to not be harmed anymore, to not be desirable anymore. And so they looked through all of these things and noticed that behind so many of the, what we call bad habits were in fact trauma responses, were in fact people reacting to things that they had lived through and that they turned to these behaviors as a way to cope. And so when we look at ACEs, and again, these were people that, the initial study, I mean, the numbers were kind of staggering. Like people that had, more than 4 out of 10 ACEs, which is something like 23% of the population. And these were people who were employed, living in Southern California, at jobs good enough to have private insurance because it was made by the Kaiser Foundation. There have been a lot of books on the ACEs project and a lot of the ACEs research. But what we find is that, yeah, sure, ACEs scores are linked to mental health challenges, of course, like rates of depression, rates of, substance abuse, and so on, and as well as behavior-mediated diseases. They're linked to emphysema and diabetes, liver disease, but a lot of these things, one could argue, would be through behaviors. But they're also linked to higher inflammatory and autoimmune disorders. They're also linked to higher levels, or higher likelihood of having chronic pain, of having other, mystery neurological illnesses, or sort of that sort of blurry, diagnostic category of sort of neuroimmune, neuroinflammatory disorders, of which long COVID is one of the ones that just added itself to the pack a little while back. And so there's something physiological happening when trauma changes the brain, and it really creates health challenges as well as the psychological challenges that we're going to talk about. And when you look at these questionnaires, they're not minor things, right? Like I work with moms and children, and I hear a lot of people saying, well, I'm going to traumatize my child if I, pick them up and carry them out of the store, or if I let them cry at night, or if I, and when you look at I actually kind of often reassure people to look through the ACEs questionnaire. You'll reassure yourself that really the bar is pretty high. And it's kind of, when you read the descriptions, you're kind of shocked at how do so many people have 2 or more of these things, For example, one of them here, I think it's not properly written in this little picture, of course I can find, but when they say divorce, they don't mean divorce, they mean a parent becoming absent, right? Yes, that could be through divorce, but that could be through, death, incarceration, whatever. The idea is that, you have 2 parents and all of a sudden you don't anymore. So that's somebody who's divorced, who's co-parenting adequately without conflict. That's not considered the ACEs in this respect. Do you know what I mean? And when we say neglect, physical and emotional neglect, we're not talking about, my parents didn't always, give me everything I wanted. It really is the bar is quite high. What we do see a lot in childhood, of course, is a lot of trauma bonding, which we're going to get to later, but the idea that basically as someone harms you when you are powerless, one of the defense mechanisms that you can develop is to become very appeasing of that person, to try to become closer to that person, to try to increase your attachment to that person in hopes that, in the subconscious hope that this will improve your relationship and make the bad things stop, or at least reduce. And so it's not rare, and I think those of us who work with children know this, for an abused child to be very protective or even preferential towards their abusive parent sometimes. It's not always, but it does happen pretty frequently because of the way the childhood brains, children are powerless in our society, unfortunately. And so when you take away people's power to change their situations, they will adapt however they can. Otherwise, all of the physiological responses are the same in children as they are in adults, but because of the head start, they have decades to develop and practice more chronic versions of the trauma responses that we're going to talk about here and what those mean. So, this is the only slide where I specifically talk about the ACEs and about childhood trauma, but I wanted to know if you guys had other questions or things you wanted to know more about specifically that part before we go to the responses themselves. Yeah.
Is there such a thing as a child not even remembering
Yes.
that he or she may have been?
Yes. It's very frequent. Very frequent. We'll talk about why, because it's one of the defense mechanisms.
Okay, because then, so you will talk about
Yes.
what happens.
And why that happens. Yes, absolutely.
Okay,
Yes, for sure.
thanks.
Yeah. Yep.
When is the scale used? Like in what context would?
So, I mean, I try to teach to my residents about how it's something that can be helpful to just know about everybody, really. I mean, in the sense that if you're providing healthcare, if you're providing social services, it's nice to know. The problem is twofold. It's hard to give somebody a questionnaire like that and then receive the results and not know what to do with it, right? And so, what do I bring up? Do I address this? Do I, you know what I mean? But at the same time, if somebody is dealing with health conditions, for example, or if they're dealing with health conditions that we know are affected by ACEs scores, or if they're dealing with a diagnosed personality disorder, or if they're diagnosed with something that, like one thing I tell my residents is what we call borderline personality disorder should just be called abuse-related personality disorder, right? Like there are no cases that don't happen without a pretty severe history of abuse. So when you know these things in a way and you realize, like, look, this is what you were given, and it wasn't enough, and you managed to build something on very shaky ground with very few tools, and it's very impressive that you did so. But sometimes in order to help solidify the structure, you need to go back to the base. You can't just pile on more when the ground is so shaky to start with, right? And so it can give you an approach and a way to open the conversation and a way to sort of understand and also make the person realize that, like, they aren't the ones at fault. Do you know what I mean? People will often feel, well, I'm just weak, or I'm just bad, or I'm just like incompetent, or I, am not able to blah, blah, blah the way other people can. But you weren't given the same tools. You weren't given the same love. You weren't given the same safety. And so you've got to go back to the basics. And I feel like knowing that part can help. You will often have people that, as the lady there mentioned, like, that will not necessarily report things because they don't remember them. And we'll talk about what happens to memory in chronic trauma as well. But nonetheless, I think most people do remember a vague sense, and be able to, for the most part, I think, answer. But I can't necessarily say you should automatically do this, right? But it's just nice to know that it exists. It's nice to know that it's been studied, and it's nice to know that at least we're no longer calling it a personal failing anymore. Yeah.
As a scale, are there some categories that hold a heavier weight?
No.
Me or her?
Sorry.
Okay.
Yes, sorry.
So are the doctors at the KMHC going to be like doing this with their patients?
I don't think so, in the sense that I'm part of them. I don't even think the skill is still in my patients, though. We do talk about sort of histories sometimes, right? I would love to give this talk to my colleagues. I don't know how many will be willing to integrate and how that works, because the problem is that trauma-sensitive care is a whole other issue, right? It's not that complicated, for example, to treat, trauma-sensitive gynecological care, right? It's something that I try to offer myself, although most of the time people will just refer to me instead of necessarily having to go through the, I'd like to see it. And
to help the patients, like, with all of these issues, health-related issues that are clearly from trauma, and all the doctors are doing are giving pills and giving medication and not dealing with the core issue.
But this is the hard part, I think, with our current system in general, is that mental health is so underfunded and underavailable compared to anything, compared to physical health. And so, especially when you look at, for example, family doctors, they're the only person you can access in a reasonable way that's free, right? Like, you can't necessarily get easy access to physios or psychologists or, anything else. I think, I don't think, my understanding is that I don't think we have counselors or therapists even at KSCS that specifically do trauma therapy.
Maybe
right?
Linda can share a little bit.
I just want to let everybody know that there will be three-day trauma workshops being held at the hospital over the next 3 months. So one next week, one in
January. I'll be at the January.
So that'll be talking about.
That's for the whole community. That's wonderful. I didn't realize that was just for the whole community. That's amazing.
Is it for the whole community though, Linda, or is it just for the staff?
For the
But
staff.
other organizations will be scheduled.
We have gotten a lot of reminders of those, and I signed up for one second I got it because it was so interesting. So there's hope to think that 2026 hoping it'll be a bit better. But again, it's really hard because again, once you've identified, what do you do with that?
Well, it's just because I've been to other events, especially with where this came up and about having the hospital and the staff be more into our ways. And I asked that question of how they're going to do it when they're ordered by Quebec and all of this to go outside of the box. And they obviously couldn't answer me, but with you being here and being a physician, like, I think it's important to deal with our people in this way. Of helping them deal with the ailments rather than just say, here, take a pill and it'll make you better. But I I understand you don't have the resources to follow up and follow through.
It's just hard to, yeah, to get, and even most people who are, I mean, in medical training, we also don't get, we get, you know, some psychological training, but we don't learn how to do therapy, we don't learn how to do counseling. I mean, the things I can bring to my office, I can bring because of the stuff I did before medicine. It's not, like, most of my colleagues don't have that kind of background either, so it's tricky. They're happy to refer if we know, like, what a doctor wants is a referral list, right? What a doctor wants is, I want to be able to identify the problem, I want to be able to send you somewhere to people who know how to help with it, because this is not in my usual scope of practice. So I think that would be super helpful.
But
So,
even for them to recognize
absolutely, yeah.
things
Yeah.
first.
Well, I will be
is key.
pushing for sure, now that this talk is made, I will be
Yeah.
pushing for my colleagues to do an insurance with it. Yeah. You have a question?
Yeah, so you said the bar is high, so I guess my question, and then you had mentioned earlier that in World War I, whatever, then they called it, before PTSD, they called it shell shock,
Yeah.
that everybody got it.
That went to war.
That went to
Yeah.
war, right,
Yeah.
but I mean, I'm comparing it to this to say that, so are there instances if the bar is high, like, for example, if a parent was absent, that somebody's not traumatized, like,
Yeah.
what is,
No, I mean, it's all a matter of percentages, right? And there are people who, I mean, but it's not even so much like an absence, it's like, it's the loss of someone as opposed to someone who's not there. There are people who are single parents by choice and who do a wonderful job.
no, but I meant
Yeah.
that, like, let's say the parent dies.
Dies, yeah,
okay, so
sure,
they're,
yeah.
they're,
Yeah,
but people are gonna still, kids are still gonna
Yes.
integrate that in different ways.
Yep.
But it's still for everyone gonna be a trauma.
yes.
So what then did you mean necessarily by the bars?
Well, before something is considered to be, I mean, not so much the loss of a parent is one of the ones that's very black and white, but in terms of like what's considered to be, you know, physical abuse, you know, the child has to have bruises or has to have repeated incidents where they are afraid for physical damage. Do you know what I mean? Like, it's not just, you know, you swat a kid on the backside one time kind of thing is what I meant, but there was something else that you had mentioned in there that was.
Well, I was just comparing it to war.
Yeah, no, because the war, I think, was, you know, you're seeing people die around you, you're seeing, you know, so that automatically makes it to the, you know, to the immediate death risk, right? Yeah, for sure. There was a question there. Yeah.
I guess, yeah, for myself, I'm also a worker at KCS and I'm in addictions. So, you know, that this is a part of the screening tools that we do use on the addictions team.
Wonderful.
And, you know, so we did, like, at the time, call ourselves trauma workers, but it was a part of our job that we've done. And it's just that, like you're saying, is now that where it's more comfortable for people to talk about it, but it's been work that's been done for, I mean, for me, I can speak for myself as a seasoned worker, so I've been there a long time and I've done this work as incorporated in the work that I've done. And maybe not everyone has these skills, but it is a part of the work that we have done, especially, and I can speak specifically to addictions, that is a part of our assessment too, so.
If you're an addictions worker, by definition, you're a trauma worker.
Right.
That's always the case, right? And in fact, we're talking about not everybody, I mean, and the scores and the experiences themselves do, it's a percentage, it's a tendency, it's a trend, it's not a guarantee, right? There are what we call resilience factors. We're going to get to a little bit later, but sort of specifically about ACEs, but we know that there are factors that will protect children from the consequences of the trauma that they've experienced, and we know that there's things that can make it worse, so we'll get talking about those as well. For sure, I mean, because somebody, and this is one of the best approaches I've seen with trauma, is that you have to make sure that people understand that this is not destiny. That because you've had bad experiences does not mean that you are doomed, does not mean that there is nothing that is reversible here. Even if you're already an adult, it doesn't mean that the damage is done and that there's nothing that can be changed. Our brains change our whole lives. We can reprogram things our whole lives. We'll talk about that again later, but one of the worst things we can do to someone who's experienced trauma, especially really bad trauma, is reduce them down to that. And I always like to tell my patients, like, honestly, it's a part of what you've been through, it's a part of who you are, but it is not who you are, and it's not even the most interesting thing about you. Do you know what I mean? Like, you are, it's not the majority of you, there's so much more to you, and that one of the ways to healing is actually building up and shifting the focus to that. Not ignoring what you've been through, but not having that take up too much room in your ongoing development. Yeah.
So having said what you just said, you mentioned that the bar for this is really high.
For each, yeah.
Like, how high is that bar? When do you begin to flag or, you know, make it
a point to take action or?
Well, I mean, what I meant was that the bar is for each category, for the question, the answer to be yes, is reasonably high, but like for example, when they do the questionnaires, they top out at 4+, right? Like the highest category of people when they do the studies on health and stuff, things like that, is people that have 4 or more ACEs, right? So you have like the zeros, which is like a shockingly few percent of the population, like 15%. And I mean, even then, most people with 4+ ACEs in their past are living relatively functional lives that are not super affected by most things because of all these resilient factors we're talking about. But when you look at the stepwise correlation between all these outcomes, it's like a line, from like 0 to like 1 to 2 to 3 to 4, like, and again, it's a trend, it's a tendency, but it's not a guarantee. So yeah, I would say, by the time you get to 4+, I mean, obviously, if somebody told me 7, I would be like, oof, but that's where you kind of would, like, I don't think there's a certain number beyond which you would flag the person or you would start thinking, only got this person to be affected. Because somebody can have 1 or 2 things happen to them that was significant enough that it's colored their entire life.
Well, that's kind of what I mean,
Yeah.
It's, if the bar's here, there's only maybe 1 or 2 things, but
Yeah.
you don't know how.
I don't mean the bar of the overall score. I mean the bar of what makes it to each, like what each question is a pretty, like people say, well, sometimes if I speak to skeptics, they'll be like, well, yeah, but that doesn't mean that if your parents, missed your birthday party or something, you're going to neglect. I'm like, no. Like, read the question. So it wasn't so much like that a certain number means anything more than each individual ACE's question is pretty hardcore. You know what I mean? Did I miss anyone? Anyone else? Yeah.
I just wanted to answer Tina's question.
Yeah.
So the training that Linda and her team do is offered to all the physicians at Cattery. I actually took it and I had a physician in my group. So it is offered to all the physicians at Cattery, and like we have three trainings scheduled. The first one starts next week. And if we have, like we're trying to do our whole staff, but we can't force people either. People have to be ready and interested in the whole thing. But they're also,
Why not though? It's important. It's
yeah,
important
anyway, I can't answer that. I could just give you the information. And I know there's a lot of efforts being made to like make Cattery Hospital like a trauma-informed center where it's just, people can talk and be on the same page, speaking the same language and be aware of the topic. But it's bigger than that because it's KSCS, it's Cattery, it's all the different orgs. Like that's the aim, to make us a trauma-informed community. But, things don't happen overnight. So now we're sitting here, we're talking about this where we didn't 5 years ago. So we are making progress. It doesn't always go as fast as we want.
I suspect a couple of the challenges of implementation could be that if there's a relatively short timeline, like I think I found out about it like in November, and it happened to work out because I made my schedule from January to June and early November. So because I found out about October, it was okay. But otherwise, 3 days in a row, where I don't already have something scheduled, weekdays especially, it's not going to happen, right? So I think a lot of my colleagues might be caught in that trap. And then also, the 3 unpaid days to do anything is hard. And it's hard to, and as far as I know, things aren't accredited for like the nursing colleges and the medical colleges. So it's kind of hard to get people to spend 3 unpaid days doing something when they, otherwise would have to work, and it's not considered like part of the licensing requirements or anything. So I'm doing it 100% because I thought I was like, oh yeah, like I'm jumping on that, but that's me, right? But I'm not sure how we could fix that necessarily, but we could make it. I mean, honestly, I think it wouldn't be horrible to make it a requirement. I would think, but in that case, if it was staff, you'd have to pay them. Yeah. So I've condensed all the physiological stuff on one slide, and I know it's a lot, and I'll go over it, I think pretty generally, but I'm more than open to any further questions. But I wanted to talk about specifically 3 parts of the brain that are affected by trauma, and both in the acute and the chronic ways. So, the one we know about is adrenaline, right? What we used to call the fight or flight response, because we thought that was the only 2 responses, and again, there's more. But adrenaline, cortisol floods the brain, your heart starts beating fast, you get really alert, your vision can focus down. And that's the limbic system, that's the amygdala. This is part of what we used to call the lizard brain, but basically, when somebody feels danger or when somebody feels a threat, your body floods with that adrenaline that brings on a lot of the acute response. And as people have this more and more, the amygdala becomes more hyperactive, which means it can be activated by less and less severe events. So you'll have that adrenaline rush at much smaller things. So one of the ways that acute trauma can become chronic over time. Memory encoding is so important because there's a part of the brain called the hippocampus, which basically like the amygdala sends a signal to the hippocampus, which encodes and interprets memories. And at first, with an acute trauma, the amygdala is signaling this is important, and so the hippocampus will try to remember what's going on, but the emotion itself is encoded much more than the actual events. And so people will, when they used to say people will always remember how you made them feel, it's true. It is the emotion that they felt that people will remember much more clearly than the details of the event in question, for the most part. And over time, with repeated trauma, the hippocampus shrinks. It becomes less able to encode memories. Memories become fuzzier. And in some ways, it's the brain protecting itself, because in a context of trauma that you can't stop or that is repeated, then there's too much threat to constantly remembering. And so memories, I describe it, they become like little fish kind of slipping away. Like you try to pin down what exactly was this, and it just kind of flies away like a bird or slips away like a fish. You can't really remember exactly the details, even when you try, because it just doesn't stick anymore. And we know this, the hippocampus does actually shrink. The memory becomes hazy and the brain protects itself. But people will still tend to remember how they felt about something. They'll have a reaction to somebody, they'll have a reaction, an emotional reaction to a situation, even without necessarily remembering why. And there are people, like children who've got a really tough childhood, sometimes they don't remember it. They have like 2 memories before age 10. When they try to think back, their entire childhood is just a haze. Like they don't remember much, because their hippocampus has been affected, right? That they're not able to encode things as well as you would otherwise learn. And of course, the prefrontal cortex, which is the part that actually is the sort of rational brain, right? So the first thing that happens after trauma is it tries to make sense. It tries to organize. It's one of the things that's actually like the concept behind narrative therapy, narrative exposure therapy, is that you take what happens, you take the feelings you felt, and you try to make it fit. You try to make sense of it. You try to make it fit into your story, into a story, into something that will put it in its place and make it take up less room and make it hurt you less. And so the prefrontal cortex tries really hard when these things happen to sort of understand. And it actually does help to a certain extent. When I have patients who have nightmares, I tell them, well, try to find out what the lesson was. And then try to find out what you can learn from that. Like, what was the message that, like, if in your nightmare something bad happened to you, something didn't happen, say, what's the message that you can learn, and if that does happen, what do I do? Like, okay, if I have a nightmare that somebody like busted down my door and attacked me or something, then in my dream, I remember now that I opened the door even though I didn't know the person, and maybe I wouldn't do that in real life, or something like that you can use to kind of, okay, you can use this is the foundation of therapy, right? It's using your prefrontal cortex to be able to help the rest of it heal. But with chronic exposure to trauma, the prefrontal cortex also shrinks and loses the ability to make sense of things, loses the ability to reason, and that's where you get a lot of the passivity and a lot of the lack of thought that can happen with chronic trauma, where you just kind of lose the ability to really process it or think about it. Do people have questions on this part?
So would the symptoms not be just memory, but also general memory, like of daily things?
Yeah, absolutely. You lose the ability, your memory becomes bad in general. Specifically, when you try to think about bad things that happen, but your overall hippocampus is shrunk, so your memory in general can be affected, right? Absolutely. Yeah?
Because your brain is shrunk, and from what I'm gathering, it doesn't go back.
We'll get to that.
When you become an elder and you have dementia or Alzheimer's, does that progress it? Anyone else?
They haven't done clear studies yet on trauma and dementia. I suspect when they do, it will. Because certainly when you look just observationally, the people that have had trauma sometimes tend to lose memory a bit faster. But again, don't go assuming these things are permanent, we'll get to that. But yes, I suspect that we'll find one, but my understanding is that there isn't a clear link yet, but maybe some research has come out since the last time out. We'll go through the responses themselves, and obviously, you know, most of them you know, right? The fight response, right? Adrenaline courses through your body, you get stronger, you get more reflexes, you get a tendency for aggression, and you're perceived by your body as the path of survival. You lash out, you fight, and people can get these like inhuman like strength, right? Like from when they're really trying to fight for their survival. But eventually, when your body gets used to it, even perceived threats get exaggerated, right? They're met with the response. We talked about that amygdala getting upregulated, and even smaller threats become upregulated and met with violence. So long term, we call this people with a quick trigger or short fuse, the inability to sort of trust anybody because they're always watching. You know, those people who can't, you know, put their back to the door at a restaurant, they always have to be against the wall. And this is damage. This is damage to your brain, right? But I want to be clear that this response is not the cause of domestic violence. Because anyone who harms just certain people, specifically partners, children, but not, you know, they're not having this response with their boss, they're not having this response with the police, they're not having this response, you know, in a store, it is not a trauma response that's making them do this, it's a choice. Let's be clear. Because otherwise it wouldn't just be with certain individuals, right? We know that domestic abuse is more a result of your beliefs and your entitlement than it is about your emotions or about your trauma or your mental illness. Because otherwise it would be with everybody. The people who have PTSD, the veterans who come back from war or whatever, they will lash out and get fired. They will lash out and get arrested. They will, you know, like they don't have, you know, there can be overlap. People can have this and also have a problem with abusing others. But they are two separate things. And even though it's very easy for the person especially to try to confound them, it's not. So let's just keep that in mind as well. It's not a fight response if it's selective.
Question.
Yeah.
Is it also related to what you see at all? Like you see it happening, so you do it as you get older?
Like, oh, you know, if you see somebody else having
In your family?
Oh, absolutely. They can. People can, like, if somebody has been abused themselves or has the fight response, having it happen in defense of others is absolutely a valid fight response, right? Because you're traumatized by seeing somebody else hurt. That's not the same thing, right? But yeah, absolutely. I mean, people can, you know, I mean, and it's funny. You'll sometimes see like little kids attack the person that's abusing their mom, even though they're like 7. You know, and they're going to get kicked, you know, like you know this, but they just can't help it. And they're just like flailing, and it's like, you know, because they've learned. But then they're doing it at the schoolyard, they're doing it with their friends, they're doing it like whenever anybody challenges them on anything, you know what I mean? There is a variant of this, which is called flood. So sometimes that same rush of adrenaline will bring emotions, especially if you're already in a situation of powerlessness or if physically you've tried and it doesn't work. So the flood response, where all of a sudden you can't think, you have this, like oftentimes it's like tears or distress, like either panic or just you become so overwhelmed with feeling, like sort of start crying. I mean, a lot of people will have this sometimes, like even if the dominant feeling still is anger or rage, right? There's a lot of people that cry tears of rage, right? And when they tear up, it doesn't mean that they're sad. And the last thing they want is when you're talking to them is if they're sad or is if they're irrational. It's just that their response is like a flood. It just comes. And they can't necessarily stop it. They're like, ignore the waterworks. Just talk to me like I'm a person, you know? And it's important to remember that as well. Because some people will have that response and that flooding without necessarily lashing out at others. And it's hard to see somebody who's like eyes are filling, they're looking at you with they're sobbing, but the underlying anger, the underlying feeling is still anger. So you have to clarify these things. You can't just assume that somebody became sad in the middle of a fight. You know, usually they didn't, in fact. Anything on this one?
I'm not quite sure I understand this flood.
Yeah.
So
it's not the same thing as fleeing, and it's not the same thing as freezing, because you're not immobilized and you're not running away. You're bringing a lot of emotion to it, as if it would be anger, except there's still anger, but your physical response from the adrenaline isn't necessarily to physically lash out. It can just be like an overwhelm of emotion that does take away a lot of your rational thought. Sometimes, but not always, or just creates a physical response that's like a flood of feeling that is not physical violence. But it's the same kind of like you feel yourself, you know, flooding.
Overwhelmed.
Yeah, overwhelmed. But it doesn't freeze you, and it doesn't make you want to run. It makes you want to stay. It makes you want to stay in it, but you're just like, you don't want to punch, but like you just can't stop yourself from sobbing or from screaming or from, without necessarily having the like physical tension that requires you to hit.
So would it be considered like a second level of understanding of your trauma? Because you're recognizing it, you're confronting it, but now it's instead of flashing out or running away, it's your body standing in the ground, asserting themselves, but your mind is still...
I wouldn't say your mind is the clearest though, right?
Yeah.
I think that's the difference, is that it's not the same as sort of because even an anger response doesn't have to be a trauma response. People can have an anger response that is just completely justified and valid and empowering, right? When we talk about a fight response, we talk about something that's a trigger, something that comes out even when you didn't want it to, something that you don't feel is under your control, and that is not always linked to clarity or purpose.
That's why I think it's confusing. Because
Yeah, fair.
you say out of control, but yet you're speaking of it in a term of you are controlling the situation because you're not fighting.
Well, no, but it's still flooding you, but it's not flooding you with exactly the same impulses. Flight is the second one we all know about, right? Like this is the runaway, like when we were running away from predators, right? This will just get you to leave. So your adrenaline courses through again, you become jittery, restless, and in nature this is actually a cue to lighten your load. So trauma can be linked to premature labor this way, because you have enough trauma and your body's like, we can't do this, we have to lighten ourselves. Not all premature labor, obviously, right? But I mean, I did have a patient once that had 2 premature deliveries in the context of an abusive relationship, not somebody here, but, and then her 3rd pregnancy with a new partner, we were all expecting another premature labor and she carried it for 41 weeks because she wasn't scared this time. Loss of bladder control, like this is when people just pee, like they can't get it, it just comes, loss of bowels as well. And so this is linked to the evolutionary desire to lighten your load so you can run faster, right? There's a reason for it. It's not random. It's just that, and what they have studied bladder control problems, and they are higher in people who have chronic trauma as well, right? I mean, we know it's a response, but because of the way the physiology works, it can actually contribute to urinary incontinence problems, even on its own in a chronic thing. Bowel control, less frequent, but it can happen as well. But these things can all turn chronic, right? So just in the way the fight becomes a quick trigger, becomes somebody who, responds way too fast to nothing. Somebody who has a flight response can, even if they don't physically run, they can avoid, they can escape, they can just not deal, they can walk away, they can just not ever engage with anything that is complicated or that is difficult or that is emotional. And so you wind up sometimes with a lack of intimate connection with others. You wind up escaping into addictions or into hobbies or into anything really that just keeps you away and out of what you perceive to be harm's way. And what we call an avoidant personality disorder, right? I mean, we know it's also one of the forms of attachment that children can develop. Avoidance or attachment disorder is its own thing, but they're very linked, right? But you just wind up not being able to really be in connection with people because you never feel safe, so you're always one foot out the door. So it's not just a chronic response, it's not just an acute response, it can be a chronic response as well. Questions about the flight? So the freeze response is one that we just sort of became I mean, I didn't really see it come out in the literature until 10, 15 years ago, even though we know it happened. But of course, like most of the responses beyond fight or flight, it was survivors of sexual violence that were able to make people understand how this happens, right? And how freezing and just not being able to react is very much a trauma response. It's caused by the same flood of adrenaline, right? It disables your prefrontal cortex. You can't perform any voluntary action, even if you wanted to. You might be thinking about things, but you physically can't move. People report feeling paralyzed, numb, they can even report being dissociated outside of their bodies, looking at themselves. Your muscles are tense, you can't move, your breathing is fast and shallow. And this is what would evade detection by predators. There's a reason this happens. You see a predator, you freeze, so that they won't know you're there. You're not even breathing loud. And this is not something we do voluntarily, this is just something that happens to our bodies. Long term, This can look like passivity, learned helplessness. This can seem like someone who is stripped of their power, who doesn't respond, who doesn't act, who doesn't react appropriately, and underreacts to trauma around them. We've all seen those people that they see things happen and they just kind of brush it off because it's the long-term reaction of just, you just can't. And you just shut down, and then it doesn't get encoded either really, right? Because we talked about how it affects memory, so you just kind of freeze until the moment is done, and then carry on. Which can be very, very damaging to yourself and to those around you for obvious reasons, right? But again, this is not something people are consciously choosing. Yeah.
Is it possible that you have, in different situations, you react in different
Absolutely.
ways on?
Yep. For sure.
Why?
I think it depends on the person, it depends on the circumstance. I think sometimes your subconscious brain will view certain threats as, for this particular case, if I don't move, I will be safe, because I know that it will avoid me. I know it won't occur to me, or I know it will happen less to me if I freeze, as opposed to, this other one is less familiar to me, or the source of it is different, and so I'm not sure, I might have to run or I might have to fight, or, it's hard to, it's hard to know. I suspect the freeze response happens more in circumstances where part of you thinks you're maybe not immediately going to die. Do you know what I mean? In the sense that, if I just don't, I can maybe avoid this. It happens in sexual assault a lot, for sure. And there's a variant, which when I was looking at these things up, I found these variant definitions, so I thought were interesting. I mean, I'm not sure how much credence I lent them exactly, but the flop variant, which is basically similar to freeze response, except you actually lose muscle. You just collapse on the ground, can't get up, can't move, can't think. And it is linked to animals feigning death, right? So they don't get approached by predators. So it's not something I've heard of a lot when people, I haven't talked to many people who have had this response, unlike the base 4, but I guess it does happen, and it has happened. People just collapse completely and just fall to the ground and don't get up. So fawn is one that we've only started understanding in the last few years, and it's sort of a subacute to chronic response. So fawning, which is now the fourth little F, is that the brain seeks to find safety and regain equilibrium. When I mean subacute, I mean not in necessarily that same moment, although it can be. You try to regain equilibrium, you try to diffuse the threat by addressing the well-being of the person harming you and trying to make them happier or calmer. I'm thinking of a couple weeks ago in my neighborhood, there was a 14-year-old girl who got stabbed by her ex-guy who liked her that she didn't like back necessarily, who met her at school and stabbed. She's okay, but the papers were reporting that as he was stabbing her, she said, I'm sorry, to him, because she had turned him down a couple weeks prior, right? I mean, that's clearly a fawn response, and that's not even, that's an acute fawn response. That is, if I do this, maybe you'll stop, I remember reading, I said to my 13-year-old daughter, I'm like, don't ever do this! Fight! Anyway. But I don't think the person necessarily had the choice either, right? I'm pretty sure that it wasn't a conscious thing. So you can praise, soothe, or obey the person traumatizing you. You seek their favor. You become just like them. They become your favorite person. You're hoping that this will help. This will end the abuse, right? You can redefine the framing, right? So basically, your frontal cortex, even though it's immediately sort of frozen, right after it happens, you start really working really hard to reframe this in a way that might make it okay, right? There was a very old expression, even when I was young, it was still controversial for obvious reasons, but the old expression was, you can't rape the willing. And what that meant was that if somebody was sexually assaulted, they could always just redefine it as if they wanted to, or they could always choose to want to. Obviously, it's not true. But the fact that this had been a phrase for a very long time, this was something that was pretty well known, indicates that we clearly talk about, how we can try to make it all right by redefining the situation, right? This came up in the Jamgamaishi trial. I don't know if you guys followed that, but there was a CBC presenter who had engaged in sort of violent sexual assaults of various women, and one of his victims had written him in the days following this email, basically sort of, thanking him for their evening together or whatever. She had no memory of this. right? But when you look at it, it was so clear that she was attempting at the time to sort of put what had happened to her back in the box of a consensual-ish date, as opposed to the sexual assault that had happened, but what she remembered was how she had felt. And of course, this was years later, and she was part of, and they said, well, don't you remember writing this email? And she had no memory of writing the email, right? Because it was your body's attempt, your brain's attempt to recontextualize, to make sense of it, to make it fit into something that's less threatening to yourself. We used to call these things Stockholm syndrome, right? You probably heard of that. It was basically like, you know, people get like kidnapped and they would start falling in love with their captors. In fact, it's not. It's a trauma response. It's a trauma one. These aren't real. I mean, people aren't really falling in love with their captors. It's that they are trying to appease their captors. One of the best ways to do that is to truly let yourself believe it for a while in order to make it more credible. It's your body defending itself. When you take people out of those circumstances, same thing, cults, whatever, you get people out of those circumstances and they see it for what it really is once they have a bit of distance and once they're no longer being flooded with cortisol all the time. So, yeah, trauma bonding is real, but it also the only hope for changing it is getting out of the situation where you're constantly being reflooded with cortisol. You can't break a trauma bond while you're still with the person. It's just not going to happen. And we see that a lot of, obviously, domestic violence, right? We see a lot of trauma bonding. Especially when someone's been beaten down enough to sort of, you know, nobody else is ever going to love you or nobody else understands you like I do, and like it or not, your physiological responses will betray you in a way because they will make you believe it and they'll make you respond in a way that, you know, by reducing the threat of that person, the sense of relief is so strong that you feel that it's love, which can be very difficult. Yeah?
That's kind of like, you know, individuals who are dealing with domestic cases and they're, you know, like let's say 3-4 times, like, I'm exaggerating, but I've seen like, and then so they're like, you keep thinking it's going to be different, right? Or they're going to change.
Exactly, because part of you is like, well, it's going to have to, right? It has to. And if it changes, then it all will have been different, right? It will all have been worth it. It will all have been, you know, it's like you're able to rewrite the whole past that way, right? Whereas if this works out, like if you stop now, if you give up now, then all it is abuse, right? Whereas you kind of keep the hope that maybe eventually we can reshape this and rechange the narrative so that it's just a complicated relationship that worked out and happy ever after. But in fact, no, right? I mean, that's not how these things work. It's really hard. This one is, I think, the thing that people see a lot and don't always recognize, right? And even in themselves sometimes, right? And it can really shake you to your core, and it's not something you can always address with people directly because they don't want to hear it and they're not ready to hear it and they won't believe it. But I think it's still useful to talk about it as a theory. The fact that people can know that it exists is helpful because then sometimes eventually in moments of clarity you start thinking, oh man, maybe this is happening. Like just knowing that it's real and knowing that it exists and knowing that it's a trauma response and knowing that it is your brain attempting to defend you is helpful because it makes people realize it's not a failure on their part. It's not that they're weak or that they are masochists or that they, no. It's a trauma response and it's caused by biochemical changes in your brain, specifically the shrinking of your frontal cortex. There's a flock variant, which basically, it's not exactly fawning, like it's not seeking out the source of the trauma, but basically we are social creatures, and so, you know, you'll see this in like natural disasters, mass violence. People go out in the street, they seek each other, you know, you bond with strangers and you try to move as one and you listen for authority from somewhere and you just kind of move together because there is safety in numbers, and we know this, right? Like I was in Manhattan on 9/11, and we were all out in the street and we were listening to random strangers saying, oh, you know, I heard that such and such a bridge is open, or I heard that this, and you don't know these people, but you're all moving as one and you're all going in the same place, and so that's something that can also happen. It's not exactly the same as fawning, but it's certainly a social response to stressors. Anything more on this one? This is a depressing one, I realize that.
A flock seems to be the only one that's actually adaptive.
Yes, it is. It is, yeah, because we know, and we'll talk about what things help, right? And that we know that social behavior helps soothe the adrenaline. So I mean, the adrenaline, keep in mind, is like a sympathetic response, right? It's adrenaline, it's cortisol, it's a stress response, it's the fight or flight and all that stuff, right? And the opposite of that is the parasympathetic nervous system. Okay, let's just go to the next slide. I think what we're talking about. The next one? Yeah, because I think we're talking about the they're countering them. So this is where it's at. So the sympathetic nervous system is the one that causes the rise, right? It's what sort of, fight, flight, it's the adrenaline, the cortisol, your amygdala's flooding, everything is happening. The parasympathetic nervous system is another nervous system we have that counteracts the sympathetic nervous system. And it is what causes us to rest and digest, as we say. And so this is also why people who have chronic stress and trauma will often have gut issues, because the intestines have a nervous system. It is separate from the nervous system of the brain, and it connects to the nervous system of the brain. And so when we say gut feeling, there's something to that, because our intestines have their own nervous system, and it reacts and interacts with our main one. And so, like when people say they have a gut feeling, they really do. Like your intestines actually do have this emotional connection, right? So the parasympathetic nervous system is the one that causes you to rest and digest and relax. And you can actually stimulate the vagus nerve, which goes from your brain to your back end, by various ways that actually cause stimulation of the parasympathetic system, which helps counteract the stress response. It's one of the things we teach when people have panic attacks. It's one of the things that we teach when people have stressors that are coming strong. So one of the main ones is belly breathing. People have been doing this in yoga for thousands of years, right? It's a breathing technique that's pretty well known. You put one hand on your back, one hand on your back, one hand on your chest, one hand on your lower belly. And the goal is that you take a deep breath where this hand does not go up at all, only the one in your belly goes up. And so basically, it's like, breathe so that you're basically breathing into your belly and you're lifting up that other hand when you inhale, and the other hand is going down, but this one doesn't move. And it takes a while to practice, but when people practice on their backs, they can actually do it when they're sitting or when they're, and you feel, it's weird because it makes no sense because your lungs end here, I know this physiologically, but you honestly do feel that your breath is going further. You feel like your breath is going deeper all the way into your belly when this rises. And it's not, there's no air down here, this is your intestines, right? But it stimulates your vagus nerve and you absolutely do feel as if the air is going past the physical confines of your lungs into your belly. And there's different ways of doing this, box breathing and so on, but like there's the deep, slow breaths to the point where sometimes people will actually, like if they're stressed or panicking or even in general, they'll sit up and you feel actually dizzy from the amount of from the parasympathetic stimulation that you can get. Humming stimulates the vagus nerve. There's a reason why people have had meditation mantras. The ohms and the various other, like humming will stimulate your vagus nerve. So if you do like closing your eyes or meditation and you hum, it will also stimulate your vagus nerve, which stimulates your parasympathetic nervous system, which calms down that response. And laughing also stimulates your parasympathetic response. So there's a reason why people crack jokes or why people laugh when they hurt themselves. Because when you laugh when you hurt yourself, it actually does make it hurt less, right? When you hurt your foot. But there's a reason for that. It stimulates your parasympathetic nervous system. So this is something, it's pretty easy to look up, like there's various techniques, but this is one of the ways you can counter the acute response when it happens. And this is also one of the ways that you can overall reduce the chronic overstimulation of your sympathetic nervous system. So this is why people will heal from trauma, from post-trauma and so on, by doing things like humming meditations or belly breaths or other sort of practices. There really is evidence to those, right? You don't always need pills, you don't always need treatments. I mean, some people will too, but another thing too is oxytocin release. So oxytocin is what we call a love hormone, right? So it's released through physical touch. It's released through sexual activity, if it's pleasant sexual activity, otherwise no. It's released through social bonding, having coffee with a friend. These things release, what we're doing here, right? To a certain extent it releases oxytocin because we feel like we're all together doing something. This is also why that flock response is actually helpful, right? You go with other humans and all of a sudden you feel safer. Breastfeeding also does. When oxytocin is what causes your canals to open for the milk to flow. But even like for example, even when breastfeeding isn't working out for whatever reason, I tell like moms, for example, always do the skin to skin even if you're not breastfeeding. Skin to skin isn't just for breastfeeding. Skin to skin works for its own way. It regulates everybody.
I've heard in the military, and I brings up a little bit of reluctance. I've heard in the military sometimes they do to try and avoid PTSD. Obviously, it's not a lot of the same kind of abuse that would be in the same situation. They do trauma or resistance training. Does that work? In any manner?
Like weights?
No, not necessarily weights, but they do resistance training where they're like, the classic, the yelling in the face kind of thing. That's actually resistance training. It's a kind time it's a form of training.
Oh,
But
so it just loves the responses.
just to
Yeah.
exactly flow the responses.
But that's
I'm just curious to see if that's ever been something applied before, pre or post, like an abusive situation.
I would actually think that if anything would, if what they're trying to do there would not be to stop people from being traumatized, it's for them to not respond to trauma as strongly as they would otherwise do, right? That would be a way to traumatize you more so that you condition the responses that you want, which is not necessarily the fight or flight, but to be able to tolerate and so on. I mean, one thing that really disturbs me about the military is when we look at the First World War, something like 20% of the soldiers that came back had ever fired their weapon. Because as humans, we don't do that. They talk about how we're like red in tooth and claw. We're not actually. We're the most highly socialized species in existence. And we're not actually wired to hurt each other. And so when they would send these people to war, and then they would come back, and most of them haven't done anything violent. They just sat there and were traumatized, right? And then they started working on it more. Second World War, you still had not many people had fired their weapon, not many people had actually killed anybody. They started working on it in the 50s and 60s and changing people's minds through various ways. We've all heard of them, right? And by the 60s in Vietnam, the soldiers were being banished. And so when they came back, they were even more traumatized than the previous ones, because hurting people also causes you trauma. It also affects your sense of self, because we know that it's not physiologically right, and we know that as a species it's really counterproductive. And so it actually causes people harm also to hurt people. And so they desensitize their soldiers, and now we have like this really high rate where people who are in the military are being trained and desensitized so that they can commit violence, and they will commit violence. And another way to make it even easier is to make the violence remote, right? Like you do it through drones, you do it through video games, you desensitize through mass exposure to, not violent content necessarily, but the idea that you could do something at a distance and not necessarily be part of it. So I certainly don't think that historically the military in dealing with its active troops has done anything useful to prevent or reduce trauma. I think they're trying to do some work with veterans, but that isn't usually, the military can hire people that are good, right? But that's not the people that are working on combat readiness. These are people who are veterans who are out of the service and who've already been hurt. I definitely don't think that triggering somebody more will ever do anything good. So there's a couple of ways you can counter chronic trauma responses too, actually. So I don't know if you guys have heard of EMDR, but it's eye movement desensitization and processing. So something about it, when you are moving either your eyes laterally or you can do tapping or some other, like basically while you're recalling an event, you do a secondary source of input, a secondary source of stimulation that seems to somehow unstick the trauma from the deepest parts of your memory and allows it to be retreated more successfully, allows you to reprocess it in a different way, in a way that is less, you can reinterpret it as something that is no longer causing a current threat. It's one of the few things that it's a theory, right? We're still not sure exactly why, but we do know people do better with it. So is it available for free? I don't think so, but we'll talk about resources later. For ACEs in particular, what we talk about is safe, stable, nurturing relationships, SSNRs, so even but this is the key. How children do well after childhood trauma, or even during childhood trauma, is more people in their lives that are safe, stable, nurturing, whether it's a teacher, a coach, a neighbor, an extended family, their friends' parents. Children who are living with trauma, the more they can have more safe, stable, nurturing relationships in their lives, the better off they will be. It's the strongest resilience factor we can have, and it's actually the one I think that we, as individuals, can probably affect the most out of all of these things. And so, if someone is dealing with something, just having you there, even if you feel like if you're counseling somebody who's going through domestic violence or child abuse or whatever, just having you in their lives, having you non-judgmental, having you stay there, having you care about them is therapy. Even if you feel like you're not doing anything, even if you come back and it hasn't changed over decades, you are doing something good, right? Like this SSNRs are the key specifically to childhood trauma, but it helps throughout the lifespan. And honestly, I want to talk to you guys about Tetris. So they did studies on this, and I know it sounds really weird, but it looks like maybe playing Tetris, you guys know Tetris, right? The little block game. So it looks like it might actually simulate the EMDR movements. And so they did studies among different populations of risk. So they studied with veterans, they studied with women that underwent emergency C-sections, they studied it with people with childhood trauma, and literally they had people play at least sometime before those memories were encoded. So sometimes between the incident either the incident or the recalling of the incident or the emotions surrounding the incident. They had people play 60 minutes of Tetris before their next memory encoding session, which was that night's sleep, so anytime before bed, and play anytime before you consolidate that sleep. And there was a reduction in symptoms. And more recently, in the last couple of years, some veterans have increased their hippocampal volume by MRI because of this. So, I mean, who knows, right? Like, we talk about brain plasticity and we act as if it ends at age 25 and it does not. So I think there's a lot of hope, actually. And we know people can be really harmed and really in a bad place, and through safe, stable, nurturing relationships, through re-exposure, through therapy, through all kinds of things, can just literally reinvent themselves. And it's not like you're taking away the parts that were harmed. You're just building back up, right? You're making what happened to you part of your story, but not defining you, and you are building yourself up to something much greater. Yeah?
Is it just Tetris or video games?
Just Tetris.
Interesting.
Yeah. I mean, I'm not sure the Tetris, but I'm pretty sure Call of Duty. Yeah, it's just Tetris.
So you're talking about healing the brain, but once the memory is not encoded, is it possible to gain it back? Because
Yes.
sometimes there's a lot of distress related to not remembering an event, and sometimes there's no memory at all. So is it possible to, at one point, because some memories can be there, like you said, emotions and also like physical memories, but the images or the recall of the event is not
always clear.
available anymore, but is it possible to do
It's
that?
so variable, right? Like in the 80s, the problem was they were trying to do things that they called like, people were sort of unearthing traumatic memories and stuff, but that turned out to be not so real. Our frontal cortex, our prefrontal cortex, has such an amazing ability to protect us and to what we call confabulate. You see this with people with alcohol use disorder, is that over the years they develop something called Korsakoff syndrome, where they just start making up answers to things. And just because they're part of their brain that understands pertinence and truth has been affected, so they'll come up and answer something and it'll be very good. And so there's no reliable way through therapy to unearth old memories without risking creating fake ones, right? And we are so good at telling ourselves stories, and we are so good at changing our narratives that it can be really hard. So I wouldn't necessarily focus on trying to recover specific memories. I would work on trying to recode the trauma so that it doesn't feel bad. You know what I mean? So that the pain that comes up is lessened. When they talk about helping with PTSD symptoms, they're not talking about being able to recover lost memories. They're talking about being able to not have the physical triggers, the emotional triggers, not having the emotional pain be as strong. It's not so much about being able to think of the actual things. And I know it's hard because some people are like, but if I only knew the truth. People are telling me all these different things, and but what I can say is if somebody says, well, people have told me this story, but I know it doesn't feel right to me, trust their gut. Because if it doesn't feel right to you what they're saying, no, that's not how it went. I don't remember how it went, but that's not how it went. You know, you remember how you felt much more than you remember the details of the thing. So if they were like, no, you were fine. You know, no, I wasn't. Maybe I looked fine, because many of the trauma responses involve looking fine, or even acting like you were fine, or acting like you were consenting, or acting like you had no issues, right? And you're like, I may have looked that way to you, but I know how I felt. And that is the one thing you can trust, is how remembering how you felt. Remembering what happened, not so much. Remembering what you did, not so much. Remember what happened to you, not always. But remembering how you felt is almost inevitably accurate. But I mean, and honestly, sometimes, I mean, I wish I could do better, but we can't. The risk of confabulation is too high. People will sometimes, honestly, their frontal lobe, all the logical part, they'll create a narrative that will soothe them. And honestly, if it's not harming anybody else, it is what it is, you know? Like narrative exposure therapy is about trying to have people create an underlying thread and story that defines their lives and that reinforces their sense of self and that reinforces their self-esteem and that makes sense of what's happened to them. I have no problem with people doing that by whatever means they want to, as long as they don't harm others. Yeah?
Because when it comes to sexual traumas, you know, society is very socialized into like giving a lot of importance to mental facts and you know, feelings and how I felt is not valid. So sometimes, you know, when you don't remember things, it's like family members' reactions that are really tougher, and also if you go through the justice system as part of it, so.
John Gomeshi got off. The guy who was victim wrote in that email, he got off. Because we don't understand trauma responses enough on a judicial level to understand why that would happen. You had a question in the back too?
What about chronic lying? Like, is that part of severe trauma? And is that something that someone will grow out of, or if they've done it their whole life and got away with it, they're just gonna die like that?
I think I would put that under flight. No, I think it can be a defense mechanism people develop, right? I think it can be a defense mechanism because the idea is that if people know me, I'm in danger. If people understand the truth, I'm in danger. And I think I would put that under flight response. I think that I would put that under one of the versions of how you can run away from things and how you can avoid intimacy and how you can avoid being known. Because being known is too dangerous, being seen is too dangerous.
Well, what if you're no longer in danger, but now you're just, that's just like a go-to.
But that's how it works, right?
Yeah.
There's fear behind it, right? Even and people sometimes don't even understand why they're lying. They're like, why did I don't even know. Like, I could have even just said the truth, you know. And they're not consciously realizing, like, but you have to address that. You have to be like, what is it that makes you afraid? Because the proper word is fear of being honest. What will happen if you're honest? What happened to you when you were honest?
So in your experience, do you ever see successful turnarounds, or?
I mean, I'm not a therapist, right? I'm a GP, but I think if people are truly willing to understand that there's a problem and want to change it, I think the sky can be the limit. I think that these things can be worked depending on what it comes from. I mean, and it's kind of funny because a lot of times when you see trauma specifically, people often think, well, when I understand where it comes from, I'll be able to automatically fix it. And that's actually not true. That's like the first part, is to understand how you develop the responses and why it happened. But being able to change the actions as a consequence of that is a whole other step. So insight is important. Knowing where it comes from is important. It's often the first step. Because then you can consciously tell yourself, I'm doing this because of this. And then you can try to soothe yourself via whatever techniques can help, so that when you're considering making this decision, you can try to soothe that fear response on your own before making the decision to use one of your destructive responses.
Have you ever witnessed anybody successfully transformed?
I haven't specifically seen chronic liars. I have seen people recover from addictions and from, you know, lack of emotional. I mean, chronic lying is its own thing. I'm not a therapist, right? Like I worked with populations that typically were in a bad place and not necessarily at the healing part. Yeah. But again, I think when you consider it to be a fear, when you understand that it's a fear response, when you understand that it's an avoidance of intimacy, and that it's a flight response, and it's a fear response that comes from the desire to protect yourself via the flight response, then you kind of see it's like it's an avoidance escapism technique. Then you can kind of understand and at least start moving in the right direction. Yes, you have a question?
Yeah, what is the women undergoing C-sections about?
So the emergency C-section. So when you have an emergency C-section, like, and this is like, at my hospital, maybe like 2%, right? Not every C-section, but like the 1 or 2% of deliveries, they're like, we've got to go right now. This baby's crashing, like, whew, you know, whip you back, like splash, cut, baby's out in 4 minutes. And everybody's okay after, but you're like I'm traumatized from them. You know what I mean? Like, and I'm not the one undergoing them, but the people undergoing them, and you know, and like the moms are traumatized, the dads are traumatized. Like the dads are like, I'm gonna lose both of them. Like everybody's freaking out. Like the moms are like, is my baby gonna die? Like what's happening? I have no control over this. Like the powerlessness involved. Absolutely is a trauma. Not even a question. It's a trauma.
Just because that happened to my daughter during COVID.
Yeah.
And I never thought of it as a trauma.
It absolutely is.
Wow.
Yeah. Now the C-sections that are less stressful, like the ones that are like, you know, the ones that are like immediate. Yeah.
And she didn't speak French, didn't know French.
Yeah.
And they just took her and no nothing, no explanation in English.
Well, that's unfortunate. I mean, and one of the ways that we as health providers can and should fix that, and I actually did a podcast, although it was in French, on obstetrical violence a little while ago, that talks about like how people can really feel certain obstetrical experiences as violence, and how the very least we can do as healthcare providers is, even if you can't explain before, you have to explain as soon as possible afterwards, and go in and go over everything that happened and why, and apologize when it's appropriate to apologize. You know, there's times that I have to like declot a uterus because somebody's hemorrhaging. But if you don't have an epidural, it feels like I am gutting you. And it's like, I'm so sorry, and I'm saying it, but I'm not stopping, and I'm not necessarily even always asking permission because you're losing 500 liters a minute, milliliters a minute. So like, then afterwards I'll be like, I am so sorry, look, I'm really sorry I had to do that. And interestingly, the people that really it was an emergency, if you go and debrief and talk, they will understand, they won't be mad at you, and I think it really goes a long way to, your frontal cortex then can help, right? It has a story as to why this happened. You can make sense of it. You get a head start on being able to fit it into what happened. You know,
Still can, and it's 5 years.
oh, yeah, so was that at my hospital?
Yes.
Oh, I'm so sorry to hear that.
Yeah.
I mean, it's something we try to talk about with our colleagues. I think we're all trying to get more like,
I mean, maybe
Yeah.
COVID didn't help, you know.
for sure. I mean, we're all trying to get more sort of sensitive to these things, and certainly, yeah.
Wow.
So I wanted to talk about some resources that people can have that I recommend. So there's some books here that I mean, there's a couple that I haven't read yet myself, although I'm looking up stuff I really wanted to. I do. So getting past the self-help EMDR book, I haven't read, but I've heard it's really good, and I've read around and heard that it's like very much a way that people can actually sort of do their own versions of EMDR, you know, with or without Tetris, I guess. The Body Keeps the Score, I have read it. It's a little bit dense, like it's pretty academic. It's like, and it's not an easy read at all. So if people have themselves a pretty like sensitive trigger, be careful because what?
It's very depressing.
It can be depressing indeed, but there is hope. He talks about it, right? But The Body Keeps the Score is is like one of those classics of trauma literature, but it's like I said, it's kind of dense. Reinventing Your Life, it sounds like one of those pop psychology nonsense books, but in fact it's written by a very legitimate psychologist. And one of the nice things is that Jeffrey Young in this book does go through different, what he calls life traps people fall in based on experiences they've had, a lot of which are traumatic, and what our defenses are, what our responses are, and how we can identify them and how we can counteract them and work to counteract them. He gives techniques on how to do this. And what I always tell people who read Reinventing Your Life is that at some point you will see a description of something that will make you cry. And that makes you know that something is speaking to you. So read that part more carefully and figure out, you know, because it talks about the various different ways that our past experiences can shape our future behaviors, including some really dysfunctional behaviors, and how we can help fix them. So actually, like for somebody, for example, who's doing the chronic lying, as the question was in the corner, for anybody who's got behaviors that are harming themselves or those around them, I do recommend, it's a good one. The ACEs Recovery Workbook is on there as well, of course, and a couple of websites. So the complex trauma one just has a bunch of other resource lists, like you know, other readings and websites, videos, necessarily not everybody else does books. And I did find the existence of a 24/7 helpline for Indigenous people across Canada that basically they can talk about things like trauma and stress and refer to resources and also just be there as a listening resource. So I haven't actually seen like reviews of it necessarily, but it certainly looked good on what I was able to see. So I thought I would put that up there just so people would know. And there's one more book and quote that I wanted to talk about on the next slide, which I just found very recently, and this book is now on my to-do list, like to read ASAP. And I thought this is really interesting because trauma in a person decontextualized over time looks like personality. And we know this is true because a lot of what we call personality disorders are in fact trauma responses over time. Trauma in a family decontextualized over time looks like family traits and aren't necessarily that way. And trauma in a people decontextualized over time looks like culture. And this was written by an African-American social worker and author who is a very smart man, from what I can tell. So, like I said, I haven't read this book yet, but I certainly intend to because I just found it recently when I was looking up for this, and I was like, wow. So I thought I would put it up there, and so that I want people to be able to continue this journey and this learning on their own, because it's not something that you need to go to medical school for. I was better at this before medical school, and I'm now probably. That's a whole other talk. So any final questions? Anything we didn't go over? Anything, like if I do this again at some point in the future, what should I do differently? What should I add? What should I take out? Like, this is the first time I've ever done this talk anywhere, so yeah.
Just a random question, would we be able to have the PowerPoint?
Absolutely, yeah. Rebecca, I'll send it to Rebecca.
The research that's been done with ACEs over the years to include environment and community and all that kind of stuff, how has that affected the stats?
You mean the research?
If you live in poverty, if you live in
Yeah.
the community, the place that you live, the environmental factors.
like how has it affected the stats?
Yeah,
I mean,
has it affected anything?
well, I don't know if they've studied research, but certainly we know that like as social structures get deconstructed and as poverty increases, that ACEs increase. This is just how that works, right? There's too many stressors, there's nothing. So I'm assuming that as we see, for example, our neighbors to the south slashing everything, that we're going to start seeing more and more trauma. I mean, there are already pockets of, for example, of everywhere really, where, you know, like it or not, the social conditions are such that how can you not have trauma experiences, right? Because like a lot of what we used to think was, for example, culture, turned to be poverty, right? And actually, like one of the things when I talk to people, like it's just so amazing to me to work in Ganawage, and if I go work, like see different, like, I don't know, in medicine they're very into like indigenous health, and they're trying to push that as like something that we have to be sensitive to. And I'm like, guys, like this is not inherent to any given population. Anybody who's traumatized and impoverished enough, you know, like Ganawage is doing so relatively well compared to a lot of other communities because of, you know, more social cohesion and solidarity and resources. And all you have to do is lift your neck off lift your boot off the neck of a population for a couple generations. Watch them flourish. Like, there's nothing inherently wrong with people, right? Like, it's what you're doing. Like, you know, and it's funny because the more I look at my own culture, because the colonial culture, like, is such a trauma-based culture. Like, when you look at, like, you know, the European, you know, mindset that I was certainly born into, like, there's a lot of trauma baggage there, and there's a lot of harm inherent in the system and inherent in what we learn about, you know, everything from masculinity to independence to power to, you know, and then it's so easy to see how that can be imposed on other people that didn't necessarily have the same worldview, right? And so, yeah, I mean, just, you know, stop doing that. You know, and see what happens. Like, you know, let people get back to their natural human, social, animal selves. You know, let us be communities the way we're meant to be, and you know, without necessarily need for, like, you know, like you could talk about the military, you could talk about medicine, you could all these structures all have such trauma-based backgrounds to them, you know, and as it's built into the structure.
I'm excited to read my grandmother's hands now, thank you, because we're getting a lot of questions around, is it culture or is it dysfunctional trauma? You know, and we don't know how to necessarily answer it in this environment because it's such a hot potato.
Well, try stopping the trauma, see what happens.
Yeah.
Right? I mean,
I'm just going to kind of extend on what she was saying. First of all, you did an amazing job. This is like you're asking for recommendations. I honestly can't. It's really good. But my question is that for like I'm not a healthcare worker, and I'm like and I don't have direct control to help somebody that's being abused. As a lateral, like if I have a friend, if I have a family member, I think that would be something that how can I help those people that I don't have direct to say, you know, you need to do these things to get better. Like, how can I, as somebody supporting a friend or supporting a family member, how can I help?
You can be a safe, stable, nurturing relationship. You can be a person who doesn't cut them off, who doesn't, by cutting off and cut them out of your life, you know. You can be somebody who's steady. You can be somebody who's caring. You can be somebody who doesn't necessarily let themselves, because people who are hurt will sometimes attempt to get safe people out of their lives because it doesn't feel right. It's not familiar to them, and so they'll like do something to trigger you or do something whatever, and you can not take it personally and not let yourself be triggered by your own, you know, responses and stuff, and just be a safe, stable, nurturing relationship. That's the first thing, right? Certainly, if somebody wants to hear about it or wants to learn more, or you know, you can talk about it in a theoretical. I went to this really interesting talk. You know, what I would not necessarily say is don't necessarily pathologize somebody like you have a problem, because nobody wants to hear that, and that's not how you get a safe, stable, nurturing relationship, right? Like, and like it or not, like none of us are trauma-free, right? Like the wounded healer thing is very real. Like we all have our own issues, and so we can't necessarily feel like just because we're not living in an XY situation that we're necessarily better or something. You know, we might have been given more early on to work with. We might have had more safe, stable, nurturing relationships in our lives that gave us the ability to create and to see something further, and maybe they didn't, but that doesn't mean we're inherently better, right? And so I'd say, like, you know, being a safe, stable peer, a safe, stable friendship is a big start. And then if you're going to share any information about this stuff, I would share it in a very theoretical way. Like, oh, I went to this talk, I learned about some really cool stuff, you know, or I learned about some stuff that I didn't think was trauma related, was actually trauma related, like, holy crap, I didn't realize. And, you know, maybe that's a bit disingenuous, maybe you didn't know, but like, sometimes it's nice to think about it in the abstract if we're realizing how much it applies to you. And, you know, one of the things that I try to do when I'm teaching residents and students is to be like, you're not immune to this, guys. like you need to do some introspection and figure out where your own triggers are. Nobody's free of bias, nobody's free of trauma, nobody's free of their own knee-jerk responses to things. And if you think you're not, then you're more dangerous. Right? You need to know what they are so that you can see when it happens, and then only then you have a chance of countering. So, like, just, I'd say, you know, be there and share what information you can, show people that there can be an alternative, right? I mean, and also one thing that helps, like, the reason why safe, stable, natural relationships help, for example, the abused child that sees that not all families are like their family, right? Like, they become, like, the other friend's mom becomes like their second mom. That's like probably the best version of a safe, stable, natural relationship I've ever heard of, right? Because those kids will grow up, and literally that will be like their other mom, like their friend's mom or their aunt or their whatever. Like, that's the one that they're going to have that primary bond with. And all of a sudden that resilience goes way up, the chronic effects of the trauma go way down, and they can see that humans do interact in a different way. People in abusive relationships, the more people they know that don't have abusive relationships, that are in healthy relationships with their partners, they'll be like, wow, it doesn't have to be like this. You know, there's not anything inherently wrong with me that this is why this keeps happening to me. You know?
The other thing that's so simple is to believe the person.
Absolutely.
You know, like before you get to all of those steps.
Yeah.
And there's been a lot of things on the internet about trauma, people having trauma. And their thing is that people didn't believe anything. And when they told somebody, they didn't do anything.
And I mean,
so that's like even before
absolutely.
we get to doing all those emotionally supportive ideas.
And I mean, and abusive people aren't always abusive to everybody, and that's what I said, that's what distinguishes abuse from a trauma response, right? Abusive people will often be perfectly normal with everybody else, and it only comes out in certain moments and in certain circumstances. That's what makes it different than a trauma response, right?
That's what makes it different.
And so, like, one book I didn't put on here because it wasn't specifically about domestic abuse, although that could be another talk, is a really, really good book called Why Does He Do That? by Lundy Bancroft. And there's actually a free version of it available online. And what I've actually done is I've like shared the site with people because like the free book, you know, people just put it on their phone and read it on their phone because it's not always the kind of book you can have physical copies of without getting in trouble, depending on what you're living with. But like Why Does He Do That? by Lundy Bancroft is such an interesting dive into the mentality that lies behind abuse, specifically domestic abuse, and that it is very different from mental illness. It's very different from trauma. It is very different from, I mean, yeah, these things probably contribute to people being more responsive, like more volatile in general, but the fact that it then becomes directed at your spouse and children is learned and is based on your views and your beliefs and your attitudes and not based on your emotions. Yeah?
Would you consider, since there's planning on growing this, having a designated like serene room with comfy chairs or you know, feet up type of sitting areas where this book you speak of that's free plays on a speaker?
Oh, I mean,
and then you can attend it like a book club, but you can lay down, relax, and absorb it, and just come back every other week, it's like a book club. But
I think an actual book club would make more sense because it's not an easy read.
Yeah.
I think an actual book club would probably make, because the thing is, children's are nice, but one of the problems is that you're alone. And what makes people feel better is not being alone. And this is why actually book clubs and group sessions are so helpful. So like, for example, if somebody decided to come up with a book club or wanted to do a book club about
I
these
just
things.
suggest that having somebody event to you like over a speaker and a dim lighting because you've been a lot of anxiety on the topic and never understood to get into them, so if it feels serene to get in.
Yeah.
And then if you're a person who can't really read because you're too emotional, then you can absorb auditory a little bit better.
Yeah.
And they have these stuffed animal arms that are like weighted blankets that maybe that can be like a suggestion. They can either opt to buy it or get it funded, and then this way everybody comes in and has like their own space.
I still wonder though if being with other humans would be even better. Like I still wonder if being with other people would be even better because it's funny because you talk about weighted blankets and this weighted blanket stuff are meant to stimulate the oxytocin release from physical touch. And it is kind of a poor substitute. I mean, it's okay, it's better than nothing, but it's literally meant to feel like a human touch. Like that's why we do it. And so is there not a way, like, one thing we have a lot of is people for the most part, like, is there not a way that we could actually just be together? And I'm going back to like the conscious racing sessions of the 70s, right? Like, especially with feminist work, like, one of the things that worked the best was getting people physically together to talk about stuff. And people were like, oh, this is just bitching sessions or whatever. No, no, no. Super therapeutic, actually. Because you're with other humans, you've got the same stimulation relationships going on, and a lot of, I mean, especially that book in particular, a lot of it is pretty, it's pretty intense. Like, I certainly wouldn't, if somebody's worried about being triggered, like, having somebody read it to you, I feel like might be kind of, well, if you're by yourself, it might be more traumatizing.
Somebody over the side with them and speak.
Yeah, or just, or a group to talk about what it means, like what, you know, I'd rather see it in a discussion group format or a book
This
format.
made us suggestion because the norm isn't working. So
Yeah, that's true. No, yeah, that makes sense. It's an interesting thought, yeah, for sure. Anything else? Yeah.
Well, it's nice to see Jerry's well together, and I love that, you know, precisely, direct, I like that information. But I also think that you're saying if you're going to be like, this is good for like people who are just learning and just learning to understand the trauma. Is what I think, like you're saying, for someone who's done some work on themselves and understand, have done, you know, that I think if you were to add, maybe when you're attending this other workshop, that you do more like intergenerational historical trauma, because a lot of the answers that you have on there would relate to that in history.
For sure.
Like you're saying, you know, the abandonment goes for us is in our DNA and can be traced back to sort of the beginning of time. So,
And
so I think
interestingly, the brain, we know the brain changes also carried on for generations. We can change the brains of our children and their future children who never met us. You have part of your trauma comes from what your grandmother went through, even if you never met her. Like biologically, it's like, it's amazing. Sorry, I didn't mean to stop it.
no, that's